Since our last sketch covered small babies, let's move to the other end of the spectrum, big babies. And for that, we'll head over to the biggest trees we know, the redwoods. The biggest fetuses we know are those that are macrosomic. The definition of macrosomia is a birth weight of greater than 4,000 to 4,500 grams, depending on which cutoff you use, which is roughly 9 to 10 pounds. Unfortunately, there's no strict weight cutoff that's universally used for this definition. We'll represent macrosomia with this 4,000-pound redwood tree to remind you of the lower end of the cutoff. To be technically correct when you're speaking of these big babies, if they're still in utero and they're measuring above this threshold on ultrasound, you should say that they have suspected fetal macrosomia, since you technically don't know exactly how much they weigh at birth. On the wards, however, macrosomia is often used to refer to the estimated fetal weight while the fetus is still in utero, which is what we'll do here in this sketch for simplicity's sake. Another way to describe large babies is large for gestational age, or LGA, represented by this bigger than 90% of trees sign. This means that the fetus's birth weight is above the 90th percentile for their gestational age. The main difference between LGA and macrosomia is that LGA considers the baby size in comparison to the typical size distribution at that gestational age. So there's no single weight cutoff like with macrosomia. Other than just constitutionally larger infants from larger parents or barring genetic disorders, the main pathway towards fetal macrosomia is maternal hyperglycemia, represented by this pregnant woman eating candy. Because glucose crosses the placenta, maternal hyperglycemia in turn causes fetal hyperglycemia, represented by the squirrel who stole some candy for herself. Since maternal hyperglycemia is so linked to fetal macrosomia, it makes sense that fetuses of mothers with diabetes, specifically type 2 diabetes mellitus and gestational diabetes, are more likely to be macrosomic. The fetus responds to these high glucose levels by producing more insulin, growth hormone, and insulin-like growth factor, which cause both the fetus to grow larger and also increase deposition of fetal adipose tissue in the shoulders and abdomen. So, why do we care if a baby is big? There are many fetal and maternal risks that come along with big fetuses. Fetal risks increase proportionately with fetal size, with marked increases of injury seen above 4,500 grams. The main fetal risk is some form of birth trauma, most commonly shoulder dystocia, which is when the baby's shoulders get stuck behind the maternal pubic symphysis. Just like how this van is getting stuck trying to drive through this tree. Data has shown that if the fetus weighs between 4,500 and 5,000 grams, that around 7% will have shoulder dystocias. If the fetus weighs more than 5,000 grams, then that number leaps up to 15%. Shoulder dystocia is an obstetric emergency. Babies can asphyxiate and die during a shoulder dystocia, usually through cord compression. We'll remind you of this devastating consequence with the umbilical cord-looking rope being compressed by the van's trunk door, which is making the driver blue in the face. Besides neonatal mortality, birth trauma to the fetus is another fetal risk of shoulder dystocias and macrosomia. Most commonly, this is a brachial plexus injury to the baby, which is caused by excessive force to the brachial plexus during delivery, usually in an effort to dislodge the baby's shoulder. We'll represent brachial plexus injuries with this Plexus brand car that's broken its side mirror while driving through the redwood tree tunnel. It's got 2 wires sticking up to remind you of the 2 nerve roots involved. Forceful traction to the baby's anterior shoulder during delivery to try to reduce it underneath the maternal bony pelvis can cause nerve injury to the brachial plexus, either through stretching or tearing of the nerve roots. Most commonly, the C5 and C6 nerve roots are affected, which leads to a syndrome known as Erb-Duchenne palsy. Clinically, babies with Erb's palsy will have a limp-appearing arm that's internally rotated due to weakness in the deltoid and infraspinatus muscles. The forearm flexors are also involved, which causes the classic waiter's tip arm, which is an extended forearm but flexed at the wrist. It looks just like this driver's arm that's tipping the park ranger for his great service to these mighty trees. In most babies, Erb-Duchenne palsy resolves with time. Sometimes during delivery, it becomes necessary to fracture the baby's clavicle to deliver him or her. Clavicle injury can also happen unintentionally during delivery maneuvers meant to free the baby from the bony pelvis. We've symbolized clavicle injury with this broken clavicle-shaped windshield wiper on this same van. Other undesirable fetal outcomes that are associated with macrosomia are low APGAR scores and the need for neonatal resuscitation. We'll remind you of this highly annoying outcome with this highly annoying part guest who's giving the redwood trees a low rating on this app. Sheesh, they're only the biggest trees around. Risks to mom will all be symbolized around this protester who's reminding us that Mother Earth is at risk. These risks include an abnormal labor course due to cephalopelvic disproportion, represented by the stop lumbar shirt that she's wearing, a higher likelihood for a cesarean section, represented by this unzipped uterus backpack, and also an increased risk of obstetric injury, such as a 3rd or 4th degree perineal laceration during birth, represented by this axe lacerating the tree trunk, and postpartum hemorrhage, symbolized by this copious red sap. Now let's go over a typical patient in whom you may see fetal macrosomia, as well as the workup, delivery planning, and prevention methods that you should employ when seeing these patients. Maternal obesity, represented by this larger mother bird, is a major risk factor for fetal macrosomia. So many of the moms you'll see with macrosomic babies have a BMI greater than 30. The risk for macrosomia increases in tandem with BMI. Those with post-term pregnancies, which are pregnancies that are at 42 weeks gestational age or more, are also more likely to have macrosomic fetuses. We'll represent this with a big egg that hasn't hatched yet. In terms of non-modifiable factors, tall women and women carrying male fetuses also have a higher risk of fetal macrosomia. There are certain aspects of a patient's history that you should pay special attention to when you want to know whether to increase or decrease your suspicion for a large baby. The first is whether or not she delivered a macrosomic baby in a prior pregnancy, as this is a major predictive factor of a macrosomic fetus in a current pregnancy. It's very important to ask about prior babies' weights because a macrosomic infant increases the risk of another one 5 to 10 times. Regardless of whether or not your patient has a history of macrosomic babies, she can still give you major intel into the size of the current fetus. Studies have shown that a mom's assessment of whether her current fetus feels smaller or bigger than the last is just as accurate as ultrasound measurements. So it turns out that mom does know best. In terms of past medical history, make sure to ask about any history of diabetes. As we mentioned earlier, the degree of maternal hyperglycemia directly affects how large some of these fetuses grow. So it follows that mothers with type 2 diabetes mellitus or gestational diabetes are more likely to have macrosomic infants. This is especially true of those with poorly controlled diabetes, so take a look at your patient's blood sugar log at every prenatal visit. Maternal weight should also be checked during every prenatal visit. It's important to counsel patients against excessive weight gain during pregnancy, as gaining more than the recommended amount can result in a macrosomic baby, which is why this big tree on the scale weighs a lot. The Institute of Medicine has published guidelines that delineate the recommended range of total weight gain for individuals during singleton pregnancies based on pre-pregnancy BMI. For those with a BMI greater than 30, the recommended range is 11 to 20 pounds. If an LGA or macrosomic fetus has been noted on ultrasound, the first hint you may have a large infant on your hands is via the fundal height measurement at a routine prenatal visit. We'll remind you to measure the fundal height with our recurring symbol, the pink fundus hat. If the woman's fundal height measures larger than the expected amount for the fetus's gestational age, this is called measuring size larger than dates, which is why we've placed the pink fundus hat higher than the sign for the tree's date. A positive screen is a fundal height that's 3 centimeters or more from the expected value. So, for example, if the fetus is 30 weeks, you would expect her fundal height to be 30 centimeters. If her fundal height measures 33 centimeters or more, then this is considered a positive screen for an LGA baby. So you would then investigate this further with a formal ultrasound measurement. The gold standard for fetal measurement is ultrasound, specifically fetal biometry, which, as we mentioned in the prior IUGR SOAP, incorporates the biparietal diameter, head circumference, abdominal circumference, and femur length to give you an estimated fetal weight. If you think that the fetus's size may affect your delivery planning, the best time to do fetal biometry is as close to delivery as possible, usually at 37 weeks or later. Quick warning about ultrasound measurements. They're not that reliable, especially when measuring larger fetuses. In fact, studies have shown that ultrasound predicts birth weights of more than 4,500 grams accurately less than 50% of the time. Using what you know of your patient's risk factors, such as whether or not she has diabetes or has gained a lot of weight during pregnancy, in conjunction with prior baby's weights and the most recent ultrasound measurement, you'll decide on how to proceed with delivery planning. Briefly, before we get into the nitty-gritty of how to deliver these babies, a quick note on induction of labor for fetuses with suspected macrosomia. While it may seem logical to induce delivery of these babies earlier so that they have less time to grow, suspected macrosomia is not an indication to deliver before 39 weeks gestational age, which is why there's this no induction of lumbar sign in the redwood forest. The extra time in utero is still super important for fetal development, and like we mentioned before, ultrasound measurements are not very reliable. However, the fetus does have to leave the nest at some point, so what do you do then? The main question regarding delivery of fetuses with suspected macrosomia is whether or not to do a C-section to avoid the risk of birth trauma that a large fetus could cause. To answer this question, you must first assess whether or not your patient has diabetes. This is because the fetuses of women with poor glycemic control have different body compositions than their counterparts. In general, these fetuses have more body fat and larger midsections. This puts them at an increased risk of shoulder dystocia, because even if the head fits through the pelvis, the body, which is abnormally larger, can't. Therefore, in diabetic mothers whose fetuses have estimated fetal weights of 4,500 grams or more, a C-section is usually recommended. We'll remind you of this with a pamphlet telling tourists to check out the 4,500-pound trees that's sticking out of this unzipped uterus backpack. There's a piece of candy next to the 4,500 to remind you that this cutoff is just for moms with diabetes. In non-diabetic mothers, C-sections are recommended if the estimated fetal weight is 5,000 grams or more, which is why there's no candy next to the 5,000-pound part of the pamphlet. So is all hope lost if you're a mom with diabetes? Can you slow your baby's rolls? Yes you can. Perhaps the most important preventative measure to take is good glycemic control in mothers with diabetes, symbolized with this sugar-free trail mix. Specifically, fasting blood sugars have been correlated with fetal weight, so diet, exercise, and possibly medication can all be used to make sure mom is euglycemic starting early in pregnancy. Because higher pre-pregnancy weight correlates with higher rates of macrosomic infants, preconception counseling should also involve recommendations on diet and exercise. While pregnant, women should be advised not to gain more weight than is recommended, which is based off their pre-pregnancy weight. Along these lines, counseling should always be provided on a healthy diet and exercise regimen during pregnancy. Finally, a more invasive preventative measure to lower weight that comes with its own risks is bariatric surgery. Specifically, studies have shown that those with class 2 obesity or higher, which is a BMI of more than 35, who have had bariatric surgery before pregnancy have shown lower rates of fetal macrosomia. Okay, that one was short and sweet. Or should we say, tall and sweet. In this sketch, we talked about big babies, specifically those with macrosomia and those that were large for gestational age. The definition of macrosomia is a birth weight of greater than 4,000 to 4,500 grams, depending on which cutoff you use. The main mechanism for excessive fetal growth is maternal hyperglycemia, which leads to fetal hyperglycemia. This is most often seen with diabetic mothers. The biggest risk for babies is a shoulder dystocia during delivery, which is an obstetric emergency and can lead to other types of neonatal injuries such as Herb Duchenne palsy or a clavicle fracture. You screen for fetal growth disorders with the fundal height, which, if the baby is big, you'll find that the fundal height is measuring greater than dates. Once you have a positive screen, you definitively diagnose suspected fetal macrosomia with fetal biometry on ultrasound. In terms of delivery, you mostly want to know whether or not you should recommend a C-section to prevent a shoulder dystocia or birth injury. If a mom is diabetic and her fetus is 4,500 grams or more, you should recommend a C-section. If a mom is not diabetic and her fetus is 5,000 grams or more, you should recommend a C-section. And that's it for our tour of big babies. I mean, redwoods. I get those two confused all the time. Anyway, catch you next time.